All right, how's it going, everybody? You guys hear me?
Yes.
I can hear you.
We
Yes.
all right. Well, welcome back. Hope you've all had a good month or so. As you might notice, there's a gamma camera behind me, and no, it's not a background; it's a real image. So I had some things I had to accomplish at work today, and rather than drive home 45 minutes in between, I just brought my stuff with me, and we had this gamma camera room was open for the next couple hours, so I thought this would be an appropriate place to have our lecture today. So hopefully you don't mind that. I am on the Wi-Fi for the hospital, so if you guys start noticing a lot of glitchiness or anything, let me know. Of course, I'm recording this, so we'll have a good recording that I'll post on Canvas a little later. But hopefully this works out. I've never tried doing a lecture from work, so we'll see how it goes. Um, I've noticed a couple of you have started handing in some of your module and things. Again, I didn't do due dates on the module just to allow you some freedom and some time to do it. But again, my recommendation is after this class, I will make sure that the test for section one, remember section one has A and B, I'll make sure that that test is available for you. And so before next class, my recommendation is that you get the test done and get those modules in. Again, not necessarily due dates, but just to keep up with the speed of the class, that would be recommended. Um, so today we're going to go over section 1B, which covers blood pool imaging, multi-gated acquisition. Any questions or anything anyone needs before we kind of get into the lecture? Okay, I'm going to take that as a no. And let me get things pulled up and then we'll make sure you guys can see it and we'll be on our way. I'm going to turn you guys up just a little bit. Okay, can you guys see the slides?
Yes.
And then the other question I'll ask is it like a full screen or are our faces in the way? Sometimes I don't do it right, so I want to make sure that I just have the slides out for you guys. Does it look like just the slides?
Looks good.
Okay, awesome. Okay, well, let's get going then. Okay, so like I mentioned, last time we talked about EKG, and I mentioned that it would be kind of an overview in some respects because EKG kind of applies to several things that we do in nuclear cardiology. So what I want to do then is now go on to one of the main exams that you can see, and you'll see how EKG has a lot to do with this one as well. But that's the gated blood pool, or you might hear it called a MUGA scan. MUGA stands for multi, the MU is multi-gated acquisition. And so the reasons that you do this scan, I've got the indications right here. This helps determine ventricular ejection fraction. So again, it's really about heart function and specifically ventricular function, ventricular volume. So we're going to see how well the heart contracts, and we're going to talk a lot about that today. It also helps us evaluate ventricular wall motion. Okay, so how not only is it contracting well, but how are the walls moving? Is there irregular movement to how the walls squeeze and how the ventricle contracts and what's its actual function? One of the main reasons this test is done as well is for pre-chemotherapy. So certain drug therapies that they use in treating chemo or doing chemo and treating cancer can cause or lead to what's called cardiac toxicity. Cardiac toxicity depresses or reduces ventricular function and can lead to basically what is like heart failure, where the heart thickens and you have less of a function. So typically what they'll do is before they do chemotherapy, they'll have you come and do a MUGA scan We'll check what their ejection fraction or the squeezing of their heart is like. What's the function? How well is it doing? And then oftentimes you'll see those patients come back as they go through their chemotherapy. And it's almost like staging like you would do in PET. But we're not necessarily staging the cancer, but we're staging the function of the heart and watching it to see how those chemotherapy drugs are affecting and if we're getting any of that cardiac toxicity. So kind of the general reasons you'll see this. I will say up front, we don't see as many of these as we used to see. Echo has taken over a lot of when we look at wall motion of the heart, they've taken over a lot of that. And so some patients will go to echo, but I still see some coming to get a MUGA. It kind of depends on doctors, what they're used to, what they've used before. Oftentimes, if a patient has already had a MUGA in the past and they're going through their chemotherapy, they won't switch modalities so that they can kind of compare apples to apples. But you'll probably still see these enough to need to know it. Also, of course, the reason I cover it is because it's on your boards, and we want you to be able to pass your boards. So hopefully, you'll get to see some of these in your workplaces. Has anybody done any MUGAs yet?
At my facility, we've done plenty. However, I do see them not do them pre-chemo, but after, like you said, to check
Yeah,
how they're doing
got you.
throughout.
Yeah, no, that's great. Thank you for letting me know. Yeah, and there may be some facilities that don't do it chemo. So, I mean, you could answer this indication with just chemotherapy in general. But a lot of practices they will do it before, so they kind of have a baseline. But it's not necessarily, if they didn't do it beforehand, they can still look at function. We're going to talk today about some of the numbers that we expect to see on how the heart is contracting and things like that. So you could do one even if you didn't do it in advance of chemo and still look and say, okay, is the heart within the standard of numbers that we should see for what this heart is doing? So that doesn't surprise me. Thank you for saying that.
I have a
I
question.
have a question.
Yeah,
Okay,
two of
go
them.
first,
So,
Kobe.
Oh, sorry. Um, so when we do a stress test and we hook them up to an EKG, does that count as gated acquisition?
So yes, we're going to talk about, in fact, this will be a good lead and I'll let you both answer and then we'll go into it. But yes, you are going to gate when you do a stress test. You can get an ejection fraction during a stress test as well. And when we go over that next class and we talk all about perfusion and about stress testing, we will. But you're going to learn the basics of what gating is and what it is, how it works now. And then when we do the stress testing, we won't. You have to relearn it, but it does apply to both. But you're going to see the difference with a MUGA scan is that we're looking at the filling and the emptying of a ventricle, whereas in a stress test, we're looking at perfusion of blood flow through the coronary arteries to the muscle of the heart. But with both of those, we do have a way to get an ejection fraction. So yeah.
I see, that makes sense because that's all. I don't know if it's the same all around across the board, but for us, we don't do a stress test without a gated.
Yeah.
Uh,
And you'll see that most places. You should be gating your stress tests. In PET, we actually gate both the rest and the stress. Um, Places are different, but certainly on a stress, you should be gating because there is going to be certain numbers that you should expect to meet. You should expect, but from going from a rest to a stress, and I'll repeat this, next on our next lecture, but going from a rest to a stress, you should be between 50 and 70% ejection fraction just to be normal. But then what you want to see is when you have a rest scan, you want to see at least a 5% increase upon stress. And so we'll go over some of those later, but yeah, you're correct. So who else had a question?
I had a question. So when we do our stress test, we utilize when we're processing it, right? And we're creating the ejection fraction. We utilize the echo to see if we're within a 10% limit. Out of curiosity, what is more accurate, the echo or the nuclear medicine myoperfusion scan?
Great question. My understanding is that the echo is a little more accurate. And you'll see as we go through today, at least in the MUGA, and we'll talk again about it when we do perfusion, but you'll see how we're calculating it. And like you guys know by now, I've heard doctors call nuclear medicine, they flip the N and the U and they call it unclear medicine. Because again, we're gathering counts and points of data And so we don't get these really high resolution images, where on an echo, you do get very high resolution images. And so you tend to get a little more accurate EF. I'm guessing that the 10% number that you gave me is probably something that your facility or those doctors have come up with kind of a protocol that they want to see match those two. What I've kind of been told in the past, or what I've learned as I've gone through my career, is that you don't really we don't really compare them. In other words, you wouldn't want to say, well, on my echo, I had a 55, but I came and got a MUGA and I was only 45. Like, oh no, what happened? The technology is different enough that you can have some leeway. So probably what your facility is doing is accounting for that leeway and saying what we expect to see is within 10%. That wouldn't be something you'd have on boards or anything like that, because that's going to be individualistic and per protocol and things like that. But overall principle, yes, echo is probably a little more accurate, and they're going to be slightly different in the numbers. Great question. Thank
Thank
you.
you so much.
Yeah, of course. All right. Any others? We'll start talking about what gating means, if not.
Is then the ejection fraction for the MUGA, is that more accurate than your standard stress test?
Those are going to be more of a comparable similarity, but they'll probably still have a slight variance, but much more comparable because you're using the same modality. They're both nuclear medicine. So in terms of being able to have the same type of image, yes, those are much more comparable. Okay, great questions. All right, so let's talk about gate then. Who can tell me, like, what does it mean to gate? Who wants to, since you guys are participating so well, I'm going to keep the questions rolling. What does it mean to
It
gate?
means that the camera tries to hone in on how the heart's pumping to get an accurate pump of the heart ejection.
Yes, you're right. So the camera typically has a 3-lead setup. Your spec cameras will have that. I have one on just on the end of my table over here, but you'll have the 3 leads. And what a gate does, in fact, I've got a little definition that will kind of roll off of what you said, because you're absolutely right. But gating is an imaging technique that uses the signal from the EKG, which is what you said, to obtain acquisition data at certain timed intervals of the cardiac cycle. Okay. So that was like a book definition, but you basically said that. So what does that mean? It means when we set up our patient for a MUGA scan, we're going to set up with a 3-lead EKG. Most cameras are going to have your lower left, your left arm, and your right arm usually in that configuration. I have seen some cameras that have a 4-lead, but you're generally going to probably be set up like this. Look at the ends of your leads, because they'll probably tell you where they need to be. And we'll talk about some variation on that, possibly, especially when we talk about stress testing. But that's your general setup. And what I've done with this cardiac cycle, remember, we talked about the cardiac cycle and we talked about the R to R interval last time, right? And that's an important interval. But you've got your P, your Q, R, S, and your T that we learned about. And essentially what I've done here is I've drawn lines from R to R. So what your camera is going to do is when you hook up those EKG leads, it's going to look for that R to R interval. It wants to find that highest peak, which is typically your R wave. And it's going to say, okay, here's my set standard of what I'm looking at. Then what it's going to do is it's going to divide it up into a certain amount of images. Now, I put, what is there, like 5 sections here. There's 5 frames here. You're never going to do 5 frames. Most cameras do like 16 or 24 frames. I just did this for simplicity to kind of look at for the first time you're looking at it. But basically what it does is it takes, in this case, say we have these 5 frames, it's going to take these 5 frames and it's going to assign them each. If you remember, when we did our class last semester, we talked about how a gamma camera works. We talked about list mode, okay? So list mode is where it grabs data and it assigns it a certain address that it can go back and then use later. So each of these frames are going to be put in a list, okay? And what they're going to do is from this R to say where we arbitrarily have our frame here, say to the T wave, that's going to take that frame and you're going to have cycles, maybe like 300 beats during this time that you image. And it's going to take that section from every one of those cardiac cycles, and it's going to put those together in that same address, in that same listed place, okay? Then what it's going to allow you to do is then go back and tell your computer, I want to grab the list that only represents atrial contraction, right? that represents that systolic contraction of the atrium. Or you can say, I want to grab the data where it represents the systolic, or excuse me, the relaxation of the ventricle, right? The diastolic. So we can take those and then we can put them into an image. Let me go to this next picture. I've broken this one up probably in a more accurate way. So this is 16 frames, and a lot of cameras do that. I think this camera right here is on our MUGAs is set up for a 24 frame, I believe. That can just be a protocol thing, but it's going to be broken up in cycles like this. So for this one, 16 frames, we're going to end up with 250,000 counts per frame. Okay. Now, that could vary based on your protocol and what you're trying to achieve. It will just make your scan longer. What this means is I'm not saying, let me be clear, I'm not saying that in so we'll take this one cardiac cycle from R to R wave. I'm not saying in this one frame you get 250,000 counts. That's not what happens. You're getting a very tiny amount of counts, right? Not very many. However, over the, like, say 5 minutes that you image the patient, you're probably imaging 100 to 300 cardiac cycles, which means that I take this frame and I take all 300 of that frame, and that's what combines together to give me the image of that particular frame. Okay. So it's these combination of frames, and then we're able to make pictures, which is why I can, like I said, I can tell the camera, I want to just look at atrial contraction. I just want to look at ventricular contraction. I want to take the ventricle and I want to do one static picture with it at systolic and then one static picture at diastolic. And now I can look at the difference in those in an actual image. Okay. So that's what we're doing when we're gating, is we're just separating it out. And then we can go back and grab our data in the manner that we need to. And again, every protocol that you have on your computers, if you go in there, if you grab one of your techs and say, hey, I want to look at the MUGA, or you could even do this on the stress portion, there's going to be a section in there where it shows you the gating, and it's going to show you how many frames you've selected. It's going to show you the time that you've desired to get to that, whatever your count value is that you want for each frame. You're going to be able to see all of that data, and that can all be adjusted and changed and depending on what your protocol is. But this is the basic idea of what gating is and what it does. Any questions on that before we move on? We'll reference it a little more as we go along, but that's the general idea. Okay. So I wanted to bring this picture up again. This was in our last lecture, but it's a good one to think about because, again, what are we looking at? We're looking at cardiac chambers, and we're looking at the blood flow through that is in the chamber. That's what we're actually imaging. So when we do these images, we're not going to have any activity anywhere in the actual muscle of the heart. It's just the chambers going through, right? So when you think about that, what goes through the chambers of your heart? Well, blood, right? So if we're going to do a MUGA and we're going to measure those volumes as they come in and out of the ventricles and of the chambers of the heart, then we have to have a way to make that blood radioactive so we can see it, right? So that's what we're going to talk about next is what we use to make it radioactive. What I have here, the radiopharmaceutical we use is going to be TEC. We're going to do what's called tagged red blood cell imaging with a tagged red blood cell kit. I listed the 140 keV, like that's probably old news to you guys at this point. You're probably heard it 1,000 times over that TEC is 140 keV, right? But you have these tagged red blood cell kits. Now, most of the time you're going to see this company called UltraTag. There is another company out there. I've never seen it or used it. Most of the time you're going to see this UltraTag kit. This kit is a preparation kit that is not just for MUGAs. It's anything where you have to tag red blood cells. So you might have a GI bleed. You've done some of those things. It's the same red blood cell kit because all we're trying to do is make a volume of blood that is radioactive. By just out of curiosity, has anybody seen anything other than the UltraTag kit? Have you ever seen any other brands? I don't know all the states out there. So any other brands that you guys have used? I'm gonna take that as a no. That's what I expected. I've asked that multiple years, and I know there are some companies out there that do some, but I've not seen them. I don't know if UltraTag just has the market or what, but that's what we'll look at today. I'll go to specifics because that's what you're gonna see. So here's how this works. When you're preparing a kit, um, first I'll tell you that, like I listed at the top there, you're going to draw 1 to 3 ml of whole blood into a heparinized syringe. So you want to make sure when you do this that you're getting a heparinized syringe, just because depending on your patient, you don't want to go up on the floor, let's say, get some blood from a patient, and then by the time you get back down, you're already starting to coagulate and clot, right? Um, Patients are different. I understand there's probably some patients out there that you could go get their blood and come back down, and it would probably be fine. Maybe the patient's already on heparin, that's fine. But it kind of depends on each patient, their clotting factors, what's going on with their health, what's happening. So just a good practice is to use a heparinized syringe. Um, but let's talk about what's in the vial, and then I'll kind of explain how it works and what it's doing and why we do all the mixing that we do. So the first thing that we'll talk about is the reaction vial, which is this here. So you'll see it's just like a little, like I think it's about 5 ml type vial. It's got a little powder solution in the bottom of it. And what is contained in that powder solution is stannous chloride and tin chloride. Okay, so what these two do is these two chemicals are able to diffuse across the blood barrier in the actual cell, the cell of the blood. It can get across the barrier, the membrane of the red blood cell. And so they are able to go in. Now, the second thing that they do is they also have attachment for technetium, right? So they have an affinity for tech. So that means we can get those into the blood cell and then have tech want to go and attach to those, right? Which is what we want. If we just put free tech into your bloodstream, you guys have seen that before when you've done other scans with pertechnetate, you're going to have all the normal type uptakes, and we'll show some pictures of that. But it's just going to go everywhere, right? It doesn't go into the blood cell, but we need the blood cell. If we're going to measure volume using blood flow, then we've got to have a way to get the blood cell radioactive. So that's how we do it. The stannous chloride and the tin chloride diffuse across the barrier, okay? Then you're going to have a couple of syringes, syringe 1 and syringe 2. And I'll also say really quick, you'll notice these are labeled 1 and 2, and you do them in that order. You don't need to have this memorized. In each of these kits, if you open it, there's a kit insert, and it literally has step-by-step instructions on how you do this, okay? So if ever anything, fails and you're thinking, oh, no, I don't know how to do this, you're not with somebody that knows, pull out that insert. If you follow the packaging, you'll do great. You'll get a good tag, okay? So in syringe 1 and syringe 2 is sodium hypochlorite and sodium citrate. So what this does is it actually oxidizes the stannous chloride and basically makes it inert so that it can't bind to tech anymore. So what we're doing then is we want that stannous chloride, some of it, to go to the blood cells, right? So it's going to go in and it's going to bind to those red blood cells. And usually when you put the blood in to the vial here, you're going to just agitate it a little bit, and it kind of that stannous chloride and the tin chloride mix with the blood, right? And that's what's happening right then is that's crossing the barrier. Then when you put the sodium hypochlorite and sodium citrate, anything that hasn't crossed into the blood cell is then made inert. Why do we want to do that? Well, because when we put the tech in, we don't want the tech getting itself onto the stannous chloride and the tin chloride that's just not in the blood cells, that's just free in the solution, right? So we need to oxidize that and make it inert. And that's what we're doing. So now by the time we put syringe 1 and syringe 2 in, both those things have become inert. And now we only have blood cells that are going to want to bind to the tech when we put the tech in. So that's, of course, our next step. Next step is you're going to add, I put 25 millicuries. A little bit of this is going to be dependent on protocol. It could be 20 to 30. Just kind of depends on what you guys do as your protocol. But most of the time, what I've seen where I work is 25. So 25 millicuries of just regular tech, so pertechnetate, into the vial. And then once you get that in, you're going to agitate that gently. Again, you don't want to shake this because shaking it can damage the red blood cells. If you damage the barrier of the red blood cells, well, now we've got open red blood cells. And so now we'll have the problem of free tech and things not tagging well, right? So you agitate it gently, and then we're going to let that sit for about 20 minutes. I had a student once ask, does it have to be exactly the 20 minutes? I would say yes. It needs to have 20 minutes to give it time for the process to happen and for the tech to bind to the blood cells. The next question I usually get is, well, what if it's a little longer than that? And from what I've been able to determine, from looking up some things, is you probably have a little bit of time. You don't need to be so stressed that, let's say it's an inpatient and you're trying to work around a schedule. You don't have just an outpatient sitting in a room with you. You have a little bit of time. I wouldn't go more past about like 15-minute time range. Like you need to get it in there and get it going. It over time can break down. But don't stress so much that you're, having a panic attack or anything, but try to get it in at about the 20-minute mark is I would say if you're going to err on longer, not on shorter though, but try to get that in. Okay.
I have a question real quick.
You,
So my tech said that after we draw the blood in the heparinized syringe, if we add it to vial one, it can sit in that vial for a longer period of time than if you like add two and then the tech. So if you are on a time crunch, can't you, is it true that you can leave it in vial one with?
that's a great question. Honestly, I don't know. I've not heard of that process. You just gave me something new to look into. Um, I wonder, you're making me want to go read the package insert again and see if it mentions that. It's certainly a possibility, but I honestly don't know. I've always just kind of followed this type of practice,
Yeah.
but that I am going to look into that. It's a good question because that if it could extend the time and give you a little longer, then certainly that's great. I would say as good practice though, anytime you're dealing with blood cells out of the human body, you're always worried about them having issues and breaking apart and things like that. So my feeling is to try to do it according to kind of this protocol. But yeah, I'll
Okay.
look into it. Good
Oh,
question.
thanks.
Yeah. Okay. Any other questions on this part? Okay. All right. So let's talk about our procedure now. So we're going to do this again. We're working with tech. So as you guys probably all know well by now, you're going to use the low energy, high resolution collimators. Um, in terms of a cardiac study, when we're doing stress testing, we do an L mode. This does not need to be done in L mode. It's just done in H mode. You'll do a couple of different planar views or angles of the heart with this. You're going to position the patient supine on your gamma camera. I'm always going to tell you to raise arms above the head if possible on cardiac studies because, again, we're going to, especially on a stress test, you're getting, you're doing a SPECT all the way around the patient. You need arms out of the way. But even this, where we're not necessarily SPECTing, you're going to do a couple of different angles, and the angle, as we'll see in a minute, is pretty important on what you're trying to accomplish. So, and we're going to be doing an LAO. We'll talk about that in a minute, but you'll start to get arms in the way. So it's just easiest on cardiac studies to get those bones out of there, get it out of the way. So arms above the head. I understand there's patients that can't always do it. If you have to do this with arms down, it's possible, but it's just kind of dependent. And I think you'll have a better idea when we talk in the next couple of slides. But best to have arms up if you can. Prevent that attenuation. Of course, you're going to attach the EKG leads. We have to have those for a gated study. And then we're going to acquire a planar image. Typically, you're going to go about 30 to 45 degree LAO, anterior image centered over the heart. Now, this is your most important image, and I'll show you in pictures why this is your most important image in a minute here. But what I don't want you to do is look at this protocol and just say, oh, I just 45 degrees. I can see on my screen when my gamma camera is 45, just kick it over to 45 and take a picture. And we'll talk about why, because you're looking for something specific. So it's around 30 to 45 degrees, and it's probably the most important picture you'll take of a MUGA. Beyond that, department protocols can be slightly different. A lot of department protocols will do like a 70-degree LAO to get almost a lateral of the heart, or some departments will just go all the way lateral. We do an all the way lateral image, but I've seen and worked in other places where they've done a 70. It just kind of depends on protocol, but usually you have those two images. You have kind of your 45-ish, and then also your lateral.
So after you inject with the UltraTag kit, then you can start imaging like instantly?
Yeah.
Okay.
It goes through the circulation pretty darn quick. I don't remember the numbers off the top of my head of cardiac circulation. I probably should know that, but it's within within less, a couple of minutes, you've got complete cardiac circulation. So it's fast. So, all right. So let's look at a picture here. This looks like a big blur blob of nothing. I realize that, but let's start to identify a couple of things here. So, what we're looking at here is the right ventricle is kind of over here on the left side of the screen, and I've tried to give an arrow. I probably should have this arrow go a little lower because it's probably right in that neighborhood right there where you can see the highest concentration. Your left ventricle is here. Now, again, with a MUGA scan, we're going to get some data on kind of all of the chambers of the heart to a degree. But really, what we're most concerned about is that left ventricle. And I mentioned in our last lecture, and it's really typical of all the cardiology studies you do, is that left ventricle is the main pump of your heart that pumps everything to the body. It's the one we're concerned about. Same thing when we look at stress testing, we're going to be looking at that left ventricle, okay? And you can see here, you can tell this left ventricle has quite a bit more activity than the right side, obviously, because it's bigger and it's pumping out to the rest of the body. Down here, you've got the spleen. You usually will see that again. Spleen has to do with blood cells, so you're going to see activity there. Okay, another super important thing in this image, and this is where we'll start to talk about why the angle of rotation is approximately 45 and not perfectly 45. And I'll show you a better picture of this. But what you can see is you can actually see the septal wall in between the left ventricle and the right ventricle. And that's this kind of area. It kind of curves right up through here. You can see that there's a lot less activity. That's the septal wall. Okay. When you are doing your LAO image, what you're trying to do is literally separate that septal wall. On the next slide, I'll give you some really good examples and we'll do a little graphic. But that's what you're trying to achieve is you want to be able to see that septal wall so you can separate the left ventricle and the right ventricle from each other, okay? What you expect to see again here, and let me see if let's go back, is you're going to see your heart and you're going to see spleen. Some of what you see all the way up here is like your aortic arch and some things that are a little filled with blood. They're not super defined, but that's what that is when we talk about the major vessels. What I want you to pay attention to right here is this, and this is just something you should know generally as techs, but what is the normal distribution of tech? So if you give a patient Protecnitate, what are you going to see, right? You're going to see stomach, you're going to see thyroid, you're going to see salivary glands. You've seen this when you've done other studies, right? It's going to be excreted through renal and GI. So we see a concentration in GI tract often, and it's you won't see kidneys right away because it flushes through pretty quick, but you'll see renal extraction, you'll see bladder, things like that. So what I want you to be asking yourself as a tech is, I just made this red blood cell kit, and I hope I followed the directions right and did everything good, right? And if I did, then I will put my patient on the camera, and I want to see this picture right here. I want to see the ventricles. I want to see spleen. That's what I'm looking for. If I don't see those, then I'm immediately going to say, well, can I see stomach? Stomach sits right under, right under that left ventricle. It sits somewhere right in here. You can see we don't have activity there. I'm going to look. This, you can't see it really well, but up here you're not seeing it. Should be somewhere right up in here is like your thyroid, salivary up here. You're not seeing any of that. If you pull a patient up and you're trying to do a MUGA and you see thyroid, you see stomach, that means you didn't get a good tag. Something went wrong with your process of tagging that blood cell, and basically you've just given your patient Protecnitate. There is a question, and I can't remember if I did. I think I did it on your module, but it's going to ask when it asks about this exam, what can go wrong? Like, this is one of the main answers I want you to give, and probably what would be on a test is what can go wrong. Well, you can get a wrong tag, and if you get a wrong tag, can I identify that? What does it mean? What should I see if I have a good tag, and what should I see if I have a bad tag? So this is the example of what I'm talking about. You want to see these things. We don't want to see the normal tech things. Okay.
Would this be considered a medical event if you didn't get a good tag?
That's a great question. That's a really good question. I'm going to lean to no. Um, that is a good question. I'm going to write that one down. Truth is, I don't know. I haven't ever thought of that, and I have had techs get bad tags, and we haven't done it as a medical event. Um, Typically, if you're using tech, um, well, that's a hard question because there's medical events and then there's misadministration. It could qualify maybe under a medical event. That's a great question. It would not qualify under misadministration because misadministration would have to be either a great delineation in the amount of tech you gave, or it would be that you gave, I-131 when you were supposed to give tech, right? It's total misadministration. But this could be a medical event. I'm going to follow up on that. That's a great question. You're the first person that's ever asked in 4 years, 5 years.
I've done many of these, and it's always like a little meditation session before I start the process. So we have timers where we do all the tagging. We have a 5 minute one and then a 20-minute one. So as
Yeah.
soon as we put in the blood in the vial, we start that 5 minute one. And so then what helps me with the other small syringes is doing this. It's 1, 2, tech, and then you start your 20-minute timer.
Yeah, that's great. And that's great. We do the same. We have timers here and we use timers. I mean, it's just good to have good protocol and to follow it because the last thing you want is to have this happen, to inject your patient. Not only are you're now radiating your patient for really nothing, but also now you've got to figure out when they come back. You've also wasted a dose. There's a lot of reasons to just be very particular when you prepare these. So I'd recommend, yeah, like don't rush it. I like how you said meditation session. That's a great idea. To really be mindful of your process and what you're doing. So yeah, thanks for sharing that. Okay, I've got on this next slide, this is where I kind of show that I turned it into what we would usually, this 12-step color. This is typically what you would view like a stress test in. Um, and we actually do our MUGAs in this as well. We'll make this exact image for the doctors. As you can see with the 12 steps like this, instead of the grayscale that's really small increments, you can see the septal wall way better. So here's your left ventricle, here's your right ventricle, and there's your septal wall coming right up in between. So what you want to do when you set up your camera, you want to bring it to roughly 45, and then most of your cameras should have a monitor like something like this. Your monitor should have a place where you can look at that live image as you're making it, and you can adjust how much it refreshes, right? So you're going to set it to where it doesn't refresh really fast, and it will refresh less often because it will allow it to gather some counts, and you can start to see an image. And what you're going to do is you're just going to adjust that camera until you separate that ventricle. Let me give you an idea of anatomically what's happening. And if this picture is too small for the device you're looking, you can pull it up on like a bigger computer later and it should and play it. But let me push play and it should work. So what this graphic is doing is it's just taking a heart and it's rotating it, right? So your red is your left ventricle, and your bluish or purplish color is the right. And you can see that as you rotate to that lateral side, you get a separation. Let's play that again. You get a separation of the you can see that septal wall of the oh my gosh, I can't talk, two ventricles. I want to say two septum. I'm going to pause this and see if I can stop it right. But you can kind of see right there, you're getting that separation, right? And again, the important reason of getting the separation is because if we have them superimposing and they're not separated, when we start to draw ROIs to measure the volume of these things, it's not accurate, right? Because if you're taking counts, trying to get left ventricle, but you're superimposed, you're going to be taking some of the counts that are in that right ventricle. And so we don't want to be doing that. So that's what you're after. I don't care what your degree is, find it on your patient. And that's the appropriate way to do it. And I drew a line. So in case you can't really see it really well, now I've lined it out with a line right there. That's exactly where it comes up through. So if I go back, there's without the line and there's with the line. So hopefully you can see that pretty good. Like I said, if you can't see it, get something on a bigger screen later on and you can look at it, but that's where it is right there. Okay. So here's a 70-degree LAO picture. And what you can see here, the nice thing about this is sometimes when you're on this previous picture, it's hard to identify for sure where that left ventricle is. I mean, you can see it pretty good on this, but sometimes it's hard and they're not perfect. This is one of the advantages of this particular image, either the lateral or like the 70 degree, is you really can see the entire shape of that left ventricle really well right here. What you'll notice with this picture, and I talked about it a little last time, and I'll probably reference it probably in every lecture, but remember how your heart sits in your chest, okay? The heart as a cup is going to sit to where the anterior part of your heart is actually slightly to the left. Your apex of your heart is towards the front of your body, and the base, in other words, the opening of the cup end, is towards posterior, right? So your heart sits a little different in your body. It's not perfectly and anatomical with the rest of your body, and you can see that right here. But it just gives a really good view for the either cardiologist or radiologist to be able to look at this and say, okay, if I can't tell where I'm looking on here, then I can compare this image and get a really good idea of where we're at. And for you as a tech, as you're drawing an ROI, which we'll talk about next. Okay, so what I've done on this image is I've actually taken a 24 gated acquisition, 24 frame, and I've displayed it out kind of like a step. You could put this in a cine if you wanted, but I put it out in a step so that you can see. And what I want you to do is pay attention. So right here is the left ventricle, right? And what I want to do is just have you look as we look at each step, what's happening. So what you have is this step one is actually at full contraction. So it's pretty full, or at least I think one of these three is probably full contraction. But as you start to step down, especially when you get to about this fourth image, you can clearly see that it's getting smaller, getting smaller, getting smaller, even smaller as we go along to 7, 8, 9. 9's quite small, 10's pretty small, probably around 11. It's somewhere in between these, probably two, that it's the smallest, or it could be 13. It's hard to tell. But that's where you're seeing ventricular systole. You're seeing contraction, right? And so that's what you're seeing. You can actually see the difference between go from frame 1 to like frame 13, and you can clearly see the contraction that happened. And then again, it comes back out to where it's full again. This is not R to R. We gathered our data from R to R, but then when we did this protocol, we said, well, let's start with the heart full and let's watch the contraction and then all the way back to full. So again, that's just a protocol-based thing. You can tell based on the gate where you want your camera to look and what pictures you want it to make. But these are the frames that it created. And again, it took that cardiac cycle of 200 or 300 images and it laid them all on top of each other. And that's how it got your counts to get up to your 250, 300,000 counts. Okay, so that's what it looks like if you were to look at it step by step. Okay, so let's talk about ejection fraction, and then we'll start getting into some of the other data that we can assess when we look at a MUGA and what it shows us and teaches us. So calculating ejection fraction, what you need to think about is when the heart contracts, when it has that systolic contraction, it's not like the walls completely collapse, right? It doesn't empty all the way. So we have volume in the heart at no matter what point of the R to R it is, right? You're going to have some volume in the heart. Whether if you're at left ventricle systole and it's completely contracted, you still have some volume. And so those volumes are what we use and do ROIs around to measure that cardiac output, the function, and the EF, okay? And the computer will do a bunch of different things with it. But right now I want to talk specifically about EF so that you know what we're looking at. One thing I want you to pay attention to that I wrote at the bottom of this first paragraph is in nuclear medicine, volume is expressed in counts, okay? So our counts tell us the amount of volume in there, right? Everything we do in nuclear medicine is counts. So what we're looking at here, what we're measuring with our ROIs is counts, and that represents how much blood is in that ventricle. So here's how you'd figure out ejection fraction. Ejection fraction equals the end systolic volume, okay? So end systolic, what does that mean? The diastole is when it's relaxed, right? So end systolic, so it's full, minus the end systolic, so we're going to minus out whatever was left there from the first volume, and then divide that by the end diastolic volume, okay? That's how you get your ejection fraction. Now, in this is a simplified version. You are going to take into account background so that you're getting accurate counts within the volume trying to do. And so what I did here, just to help you see how it's calculated, is I did a really simplistic version. And in all honesty, this is the same thing you do with a HIDA scan or anything where you're calculating volume differences, right? So to make it simple, I used just like these simple little single numbers. I said this represented 7,000 counts. You're not going to count it for 7,000 counts. You want like 250, 300. But just to be simple, I use these numbers. So if I did my ROI, and you'll notice right here, I circled right around the left ventricle. Notice that one of the walls of my ROI is going right through that septal wall. So we've identified that and we can see it really well. So I went right through the middle of the septal wall and then circulate anything that looked like that left ventricle that was hot, right? So there's my ROI for my left ventricle. And then I did a background out here, similar to what you may have done when you do a HIDA scan and things like that. Now, I will say with the background, you always want to represent background in similar anatomy to where the heart is sitting, right? So I'm not going to want to do a background clear out here in space. Obviously, there's nothing out there, but I don't even want to do a background, up by the shoulder or some other weird place, even though there is some free tech throughout the body. You don't want to do that. What I want you to realize is that the heart sits right here and it's surrounded by pretty much lung tissue. As you go down inferior, you start getting into bowels and things like that. But pretty much the bowels typically don't superimpose except for maybe a little bit on the base. But in this case, we don't have bowels filled with much radioactivity because we didn't do free tech. So lung is going to have a little bit in there, and that's where you want to get that background. That's why I did it in this spot. When your computer may do it automatically, so you may have to do it manually. It depends on your protocol. Some places do a manual one and let the computer do one, but you want to place that somewhere right next to it in that kind of left side on the lung field. That's the best place. Now, I could have gone up a little further or wherever, but that's generally where you want to do. And that's just because that's where the heart sits and it gives an accurate representation of background. Okay. So you'll see in our equation down here, I took our heart counts, subtracted the background, okay, and that's our end diastolic volume, so our full heart. Then we according to our equation, we subtract the background, which is the or excuse me, we subtract the end systolic volume, which again over here we counted that and said our heart was now 3,000 counts. Subtract the background again, which is the 1. And so when you do the math out on these, and then you'll do the same thing again with the end diastolic volume that you divide it by, which we already figured out up here. When you do all the math on this, you're going to get 0.66. Of course, you're going to multiply that by 100 to get an actual number. But that gives you an ejection fraction of 66%. Okay. So again, you're just taking the end diastolic volume, subtract the end systolic volume with the background accounted, divided by the end diastolic volume with the background accounted for. And that's how you're getting your ejection fraction. Okay. So in this case, with these arbitrary numbers, we got a 66 EF and we like that. Right here is a number that you'll want to know. I can see this being a test type question for me and also on your exam or on your boards. Normal EFs should be somewhere between 50 and 70%. That's a normal ejection fraction, okay? And again, should increase from rest to stress by 5%. We'll talk about that more later. Okay, so now I want to look at, so most of your software, you'll run it through, you'll draw ROIs, you'll do all this stuff, and then you'll hit some kind of processing button, and your computer is going to give you a bunch of different type of data. What I want you to do with this data is I don't think you're going to get test questions on the specifics of this data. I think you could get test questions on general principles of what a MUGA is doing in terms of ejection fraction, wall motion, what you would do a MUGA for, and then what makes a quality study. So I'm going to show you all this, but you should know this as a tech so that you know what you're giving your doctor and you know whether to look at it and say, this doesn't make sense, or I have good data, or I drew a good ROI, things like that. So we're going to go through one of these. So on our computer, this is what it pops up. Your computer might not look exactly like this, but it will probably have these same data sets. The first one I'll show you is up here in the upper right-hand corner. This is actually a cine image. So it's a looped cine image that I shouldn't say looped. It's not spinning like a pet, but it's actually sitting there with a contraction heartbeat, which is a really cool image. I couldn't figure out how to get it on this slide, but it's actually a motion image where the heart will beat and contract. great image for the doctors to be able to look at when they just look at all this data and say, well, what does it look like to my eyes? I want to see this contraction happen. So that you'll typically have a cine picture somewhere on your data set. Okay, going from there, what we have here is you have your diastolic image and your systolic image of the left ventricle. So this was actually produced by the computer. This was not done by me manually. And what you see here is it's drawn an ROI. When you pull this up, the first thing you want to do, especially if your computer does it, is you're going to say, does this make sense? Does this look accurate to my eyes? Right. And so I look at it and I'm like, okay, I saw in my previous images where that septal wall was. This looks pretty accurate. It looks to me like that computer is also recognizing where the septal wall is, and it looks like it's getting a pretty good ROI. A lot of times your software will allow you to adjust what the computer did or allow you to do it manually. I left this one. This looks pretty good to me. I think it's got a pretty good idea of where that left ventricle is. And then you'll notice the systolic image, it did the same thing and it provided a background. Okay, so you've got both the background and systolic. I went ahead and just let the computer do its thing. This looks good to me. Again, if I came up and this image like cut right through the ventricle or something, I'd be like, okay, something's haywire with the computer. I got to fix this. So this is what you should typically see. So you should have those two images. Again, first off, reference those two images and check those out. Okay. So the next thing that we're going to look at here is what we call amplitude and phase. Okay. So I've written these out as kind of little definitions for you to see. But essentially, amplitude gives what we would call a static representation, meaning it's not a picture that moves, but it's a static representation of the characteristics of how the heart is beating. And then the phase is similar information, but the timing of the beating. Okay. So what you see here on this amplitude is anywhere where there was a lot of heart motion, it represented it as a lot of counts. Okay. So what that means, I want you to think for a second about how the heart actually beats, right? So you have the septal wall. In your septal wall, you have your right ventricle and your left ventricle. And your septal wall actually doesn't move that much when your heart beats because both chambers contract in like that, right? So when we're looking at a left ventricle, was just this specifically, you're not going to see a lot of motion on that septal side of that ventricle. You're mostly going to see motion going up and in, right? The apex tracks up towards the base, and the lateral wall contracts towards the septum. So that's what you're going to see, and that's what they represented in here with counts, right? So you see many counts underneath, and you see closer to the septum, you're not seeing a lot of counts because there's no motion there. And then, of course, they've subtracted out the systolic volume altogether because where that happened, you don't see any motion because that's when you get systolic contraction, that's the volume that's left. It didn't go anywhere. It didn't do anything. So it's completely subtracted out. So what this is doing is I can look at this image and I can say, I can see where the motion happened in this heart. So again, it's a static representation of dynamically what the heart is doing. Okay. That's the amplitude. Now the phase, and this is also the harder the contraction was also highlighted as well. The phase is similar in that the harder the contraction is a certain color, and excuse me, I said that wrong. I said that wrong. I already told you amplitude about hardness of contraction. This is the timing of contraction. And what you're seeing here is the ventricles, the right or the left ventricle and the right ventricle, you can see filled up here. And they've represented it in this kind of green color. And then what they've done is they've represented the atrium that have filling here in a different color. Okay. And then what they do is you go over on this phase histogram. Intensity of contraction is represented on the histogram, not necessarily on the color. So it's represented on the histogram here, but also what's represented is phase in degrees. So what I mean by this is that when two things happen simultaneously, we would say they're not happening in any degree of difference, right? If something's happening in exact opposite, right, then we would have 180 degrees of difference. And then there could be a variation between happening at the same time and something else. Okay. So the bottom of this histogram, when we see 0, 90 degrees, 180 degrees, 270, and then back to 360, it's representing when in time that contraction took place based on the other ventricles. So it compares the atrium to the ventricles. Okay. And it says where's their timing happen. So on ours, it's giving you a strength, right? And it's also giving you a time. So you can see first off, here's the ventricular contraction. You can see that's stronger, which we'd expect, right? Again, QRS complex. And then we see here, we see atrial contraction. What's that? That's the P wave, okay, right? And we know that's a smaller wave. So again, what we can see here, though, even in more than that, is you notice that just after 90, if I were to just guess on a number here, it was probably around 100, if you said 100. And you'll notice you go on, and this one's probably in somewhere of like 190, which means we're getting closer, or excuse me, not 190, probably 290. So we're getting a separation of almost 180-degree difference. Do you see how that works? You're getting that separation. And it's happening in a contraction that's not together. And so that's telling the doctor, is my heart pumping in the way it should? Are the atrium firing and the ventricular contraction and the wall motion happening? So that's what the phase does. It shows you kind of the timing. So again, intensity, timing, and intensity when we look at the histogram. Okay. Now the EF image is this one down here, the ejection fraction image. This represents counts. It puts counts where wall motion occurred. So this is kind of similar to what we did in our amplitude. This is going to just say I'm representing counts where wall motion occurred, and it subtracts out the systolic. So that's what you're seeing here. So again, it's kind of a static representation of what happens and where you can visually see your ejection fraction compared to itself. Stroke volume is similar. In this, it represents the amount of blood ejected, and the counts are subtracted. Systolic counts are subtracted from diastolic counts, and it's supposed to represent the amount of blood. So everywhere where you see activity, that's anything that was ejected. And so the areas that ejected more or that were more ejected during the time are going to show up brighter. Areas that didn't eject much, less brighter. So these are all very, very similar type images that are looking at dynamics of what the heart is doing. Then I'll show you the paradox image first. What this does is this represents activity that is in the atrium while the ventricle fills. So this is contraction of the atrium, essentially. Very similar to, in the phase one, it shows both activity. This is just showing when the atrium is contracting, and they call that a paradox image, okay? So this would tell you too if your atrium's filling, if there's anything going on weird there. Then the last one I'll show you here, well, two things I'll show you here. And this one's really cool. This is called a regional EF. So what you see here is they've taken your ROI, it's taken the ROI that it's made, and it's divided it into sections like a pie. And what it does is it calculates an ejection fraction just for that section. And you might think, well, why would you do that? And the reason you would do that is that a heart can have abnormalities in how it beats, right? It's not always going to be everything squeezing every time. And so what you sometimes see is you're going to see that portions of the wall are going to have a little bit of a funny beat. And so what this does is it separates that into individual parts of the wall and tells the doctor, okay, this is what I'm seeing comparatively. I'm seeing that what would I expect to see? Well, if like I told you before, if the apex of the heart contracts up and that lateral wall contracts in, well, I would expect to see that if I'm separating and looking at the apex and the lateral wall, I might have greater numbers than if I were up here by the septum. And you can see that on here. You got 56 up here, and you come back down here. You can't see these numbers very well, but 66, I think this one's 69. And so the doctor, that's another way to look at it and say, okay, is this going as expected? If I pulled this up and I had like 69 over here and 56 over here, I'd be going like, well, what's going on with that lateral wall? I mean, I have to start questioning at that point, is there some heart failure going on, or is there a blood flow issue and we're not getting good contraction because it's got some sort of narrowing or blockage going on? Like what is the problem here with the beat? So it just separates it in, looks more individually at the heart, and then, or at the sections of the heart. And then this is just the curve of activity of the actual contraction of the heart, right? So it starts where you've got diastole, then a systolic contraction, and then back to diastole. So this could compare these, every 24 of these dots could compare to those individual frames that I showed you, and just putting it on a count value, right? And time on the bottom, counts on the side, just so you can actually look at that curve of contraction. Down at the bottom, you can see that it actually gave you the counts that are seen in the ROIs that we did. So it's got your background, it's got your diastole, systolic, and then your background. And so you could literally take these numbers, and if you did these numbers and did the math on them, you should get this 66% EF. So it's going to pop you out that EF as well. A couple other things are up here are things like what the heart rate was, and you're going to look at right here. You'll see when you pull up your camera and you're looking at your gates, it'll usually have a histogram that tells you how many beats are being accepted. In other words, the EKG is trying to see R to R, but people's heart rates are weird sometimes. Their EKG cannot be perfect. And so when it sees an R to R, it will tell you, hey, I accept that. I recognize this in R to R, and I'm going to use this in your data. And so you see on here that there's beats that are accepted. I've got 515 beats that were accepted, and I've got 119 beats that were rejected. And so what you want to look at that when you're acquiring the image, because if you pull this up and your camera's only, if this was reversed and your camera's only seeing 119 beats and it's rejecting the rest, well, then you got to do something with your EKG. Something's off. You're not getting a good signal. Your camera's having a hard time gating. One of the biggest ways that I see this happen is obviously you're going to run into issues with people who have some of the arrhythmias that we talked about, if they're an AFib or some of the things that make an irregular heart. But the other thing that can happen, even with someone that has a regular heart, is depending on where your placement is of those leads, you can sometimes see where you'll get a QRS that's kind of the normal size. And then I've seen EKGs where the T wave, for some reason, is really pronounced because of how that is triangulating that signal with those three leads. And so sometimes I've seen where the computer says, okay, I think this is an R wave. And then it sees the T wave and thinks that's the next R. And so then it's trying to gather the data just in there. And so it can really mess it up. So you want to make sure you have your EKG leads placed in a good spot. And then most of your cameras, again, on your screen are going to have a place for you to look at that EKG, and you're going to be able to see the QRS complex, and you want to see good R waves on there, okay? If you pull it up and you've got these little R waves and they're barely bigger than a T wave, you might want to adjust. You might want to do something different. The other thing I'll have you think about is, even though on our image, maybe I'll just go back real quick. On our image way back at the beginning when we talked about the EKG right here, even though this is where these leads are designed to be, don't feel scared in moving these around until you get a good R wave. The reason I say that is because these three leads are not diagnosing an EKG. It's not a diagnostic EKG. I'm not going to look at that and try to say, okay, this patient's got ST depression or ST elevation, or they've got this kind of rhythm, right? All you're trying to do is get the R to R. So you need a good R wave. So don't be afraid to move them. I mean, try to get the best you can. Try to go in the configuration that it's supposed to be in, but don't be afraid to move them around until you get a good signal. Okay, I think I covered everything on that page. The last one I want to show you is and identify a couple of definition words that you need to know, especially when it comes to wall motion. I've gone ahead, and this is a totally different scan, but you'll see that I've got this wall motion blown up. And kind of what we see here, this is an interesting one. There could be some issues here with this heart. If you notice, when it regionally divides everything up, over here in the septum, you've got 58. You've got 69 kind of over on this lateral side, but then you have this area where, especially inferiorly, it really looks bad. So I'd be questioning, and I'm sure a doctor would question, okay, inferiorly, what's happening? Again, do we have some kind of blockage going down there that you're not getting good blood flow, so you're not getting a good contraction? Do I have a electrical conduction issue in the heart that maybe those Purkinje fibers in that area are having issue? You're going to start to question, is there maybe some heart failure going on here, although heart failure tends to go everywhere. But again, this would be that abnormality. So what I want you to look at on this one is I mentioned septal contractions usually less than other walls, but there's three terms that you want to know that you'll hear used with mal motion. And I could see these being on tests that you take as general ideas of understanding when you're talking about heart. But it's hypokinetic, akinesis, and then dyskinetic. So hypokinetic, what that means is that hypo again is less, right? And then the kinetic just means motion. So essentially, you could just, off of just the word itself, you can see that it's diminished contraction. Okay. So if we have an area of the heart, when a doctor's reading this, he might say, on this area of 56, he might mention in this portion of the slice that he sees some hypokinetic heart motion or hypokinetic wall motion. Inferior lateral hypokinetic wall motion. You might hear something like that, right? And that's what that means. So akinesis is absence of wall motion, right? So if you get anything in here that's just not moving at all, you're going to have akinesis. And then dyskinesis or dyskinetic is a paradoxical wall motion. What that means is that you might be having systolic, but you have like an outward, or you have a relax, you're looking at a relaxed phase in diastolic of the ventricle, and you have a motion going out at the end or doing something different. So that's going to be your dyskinetic. It's opposite of what it should be. Okay. So I just got an error that said my microphone switched. Have you guys been able to hear me okay?
Yeah, there was like a couple seconds where I couldn't hear you, but it was only like for 5 seconds.
What section was I in? Was it
It
just
was like 30 seconds ago.
okay? Well, let me know if you missed anything too much there. Sorry, darn it. I don't
I
know
think it
what's
was when you were starting to explain dyskinetic.
okay. Okay, so yeah, I'll just briefly, really quick again. So dyskinetic is just a paradoxical wall motion. So it's doing something opposite of what it should be doing. So the example I put on here is, let's say, an outward bulge during systole. So you expect a contraction, but you actually get an outward bulge or an opposite. So it's a way of describing what the wall motion is doing when it's doing opposite of what you expect. Okay, so dyskinetic. So those are three good terms to use. I wouldn't be surprised if those could be on a test, or at least understanding those, asking a question about those on a test. Um, let's see, I think, yeah, that's all I've got for you today. That is MUGA scans, gated blood pool scans in a nutshell. What questions do you have?
I was wanting to know that considering that this can be done planar spec, but it's typically done planar, is there a specific K count amount done for each position, if you will, or is it like a timed amount, like it's 5 minutes or it's 500 K counts?
You can do both. So your computer should give you an option to set up K counts. Keep in mind that if you're setting up K counts, it's going to possibly limit the number of frames that you can get for the time. So usually when you're thinking of getting a static image, you're thinking either throw it on K counts or I'll throw it on time, or sometimes you say whichever one comes first. We're doing something similar, but we're adding in one more thing, and that's frames, because each frame needs to be able to get up to a certain amount of counts. And so you can do both, but all three of those parameters are going to affect each other, and you're going to have that. Now, in terms of maybe answering your question more direct on a test or something, I don't think it's going to ask you on a MUGA scan how many counts should you acquire. But I would just say that it's the general idea of similar to what you would acquire under other things. On something like a MUGA where you're getting several frames, I would say 250 is probably the lowest you should see. Most static images that you do are like, 500 counts, 600 counts, 700 counts for most exams that you do. So they do tend to go a little lower on MUGAs when we're trying to get all those frames, but I would say nothing less than that. Does that help? I know it's not specific.
No, it does help. It's just things to be considering when we're acquiring our images, though. Thank you very much.
And again, I would highly recommend talking to one of your techs that maybe is one of your more patient helpful techs to students, and just being like, hey, can we look at can we go into the protocols on a MUGA? I want to see these things. I want to see like how many frames you're using, and I want to see if you're doing it based on time or just counts and frames. Go look at it.
Okay, thank you. And also was wanting to know, this doesn't appear to be smart zooms, but would a smart zoom help in this process by allowing us to see the heart better or no?
It could, because again, most smart zoom cameras are kind of angled in. So again, it's going to match the pattern of radiation. So you could get counts at least quicker. You certainly could probably shorten your time because generally you're blocking less counts, right? And so you're going to get more counts faster. So yeah, it could.
Thank you so much.
The only caveat I might give to that is that it might, well, I've never tried it, but I would question on my turning the camera. It depends on your smart zoom. So some smart zooms are all, so if I was looking at my camera head here, some smart zooms are it's all the septa are all running like this, and then they're pointed in. And then on some smart zooms, it's more like a pyramid. So you have septa on all four sides pointing into almost like a pyramid, or you have circles that are angled in to a central point. So some of that could depend on what type of smart zoom you have. Um, if it's the one where it's just the lines, you're probably good because as you rotate and try to get that septal wall, it probably wouldn't cause any problem at all. You might be able to run into problems with the other configurations. I'm not sure. It's a good question though, but you should be able to use it. If
Thank
none
you.
else, try it. Any other questions?
Yeah, sorry, quick, something quick about the rejected beats.
Yeah.
I'll turn this on towards the end. Hi. Um, at what point, and I don't know if this is going to be in the boards or not, is it 1 to or 3 to 1 ratio, the rejected beats that we should allow, or and when should we consider moving the leads around and restarting the scan?
That's a good question. Yeah, I would say so you're going to want to end up I would say with somewhere between 2 to 300 beats that you look at, which is going to also depend somewhat on heart rate. Like you're going to get data quicker on somebody that has a faster heart rate, or at least get that a number of beats. Um, but I would say, yeah, I've never specifically thought of a ratio per se. Typically, when you first start pulling it up, you're going to see really quick if you're getting it. Um,
Mhm.
so if I had to throw out an arbitrary number, I'd say, yeah, like 3 to 1 is probably a good thing to look at. But you'll recognize this pretty quick because if you're getting rejected beats that are higher than your accepted beats, then you're definitely going to do that. Keep in mind this too, though, is that these rejected beats are all data that it pushes out. So you get no counts from that. So that time that those beats are happening, no counts are happening. The other thing that you can usually see on a histogram where it will show beats, a lot of cameras will allow you to extrapolate that histogram over time and watch it as it goes. And so you'll be able to see where your camera grabs it and then where it suddenly rejects it. It's like a visual representation. So yeah, I would say a good rule is maybe a 3 to 1, but I don't think you'll ever look at it and have to wait that long. I think you're going to be able to pull it up. Every time I've done it, I pull it up and I can see right away. I'm like, oh wow, it's not accepting very many beats, and then you adjust pretty quick. So it's great question. I would just say in practice I don't have a number for you. Definitely wouldn't be on boards, but in
Okay,
helping you
that's what
be
I
a
was
better tech,
wondering.
in helping you be a better tech, you should see it pretty quick. Is what I would say. I've never had to think. I've never had to watch it long enough to think of a ratio per se. Usually can see really quick if it's rejecting a bunch.
Thank you.
So hopefully that answers. Anybody
I
else?
I just had a quick question about
Yeah.
the ejection fraction.
Yep.
Is that same formula the same one we use for a stress test?
Um, yeah, you typically won't manually do an ejection fraction on a stress test. Most of the time your computer does, but it is this
Okay.
it's similar. Um, on a stress test, it's taking it works it a little different because it looks, again, remember, you're only going to have myocardium highlighted. So it measures it slightly different, which is why I say you're not going to do it because you wouldn't do an ROI because you don't have a stroke volume inside the heart. But what the camera is doing is it's looking at the counts and it's looking at the count difference between the essentially the inside of where it sees counts. So the camera will be like, I see all the counts in the heart muscle. Now I'm going to measure the inside of this volume. And when it contracts down, it takes the difference in that motion or the I, this is a really bad term, but I want to say because you see in the middle of a heart on a stress test, you're going to see that black inside the volume, right? And so when it sees a less black when the contraction happens, that's the volume it uses to do that. So it's not doing it on in the same principle in terms of what it's measuring, the counts it's using, but it is doing a similar thing where it's taking what it's measuring, subtracting out any background and making the ejection fraction.
Okay, I only ask because I've had a patient once where they had an ejection fraction of 8. I and I was just curious how it's even possible.
Yeah, that's very low. But if you think about it, it would mean the heart's just kind of barely going. Um, I probably would question too that one to see is it legit or not. I would probably look at my gait. I would probably be wondering what happened. I'll bet you. I mean, I don't know, but when I've had something like that happen, I go back and look at my gait, and my gait's pretty bad.
Yeah, we did everything we could to like fix it, and yeah, that's the final number it
Still
came
high.
up with. So
Yeah, I mean, that's extremely low. That's extremely low. Did you gate, was you gating just the stress or did you gate a rest as well?
we gated the just the stress.
Okay. Yeah. Yeah, I'd be interesting to know if a rest image came up, something seems weird about that.
I mean, he didn't have like great perfusion anyway,
Yeah.
but you know, I was like, how are you even like the stress portion didn't even phase him. He was like, oh, like I'm just a little out of breath, like no like crazy symptoms or anything. But it was just weird.
Yeah, that is an interesting case. It'd be interesting to look into for sure. And I would also say with what you just said, it symptomatically is not always the best idea of how well your stress worked in terms. Were you using Lexiscan or wasn't a
Yeah,
yeah.
Lexi.
It's not the best determination. I mean, I've seen patients that don't feel anything, and I've seen patients that feel everything and everything in between, which is why when you're doing a stress test, you're watching EKG and you're taking blood pressures because that's your indication physiologically that your stress medication is working. And we'll talk more about that on our next one. But yeah, interesting case. Interesting to look at. Any others? I'm gonna stop my screen share. Let's see. I'm gonna see if there's anything real quick. I saw a couple messages going up that I couldn't see. Yep, we're all about the left ventricle. Make sure I didn't miss anything. Yeah, good idea. Maybe picking up bowel. That could be another explanation, possibly. Hard to say. Hard to say. But yeah, if it was picking up bowel, if you had some inferior bowel down there that was overlapping your inferior wall, it could be obstructing that. But who knows? Maybe you guys looked at that too. It's hard to say. Okay, I'm going to end it unless anybody has any more questions. I'm happy to answer more. But we're done. If you guys are done with me, again, work on your assignments, work on getting the test done and everything. If you can do it before we meet next, that'd be great. All right, I'm going to stop this recording.